Immediate care of acute orthopedic injuries. Let's start off with what is immediate care. Care should be given immediately after an acute orthopedic injury. This is a subset of acute orthopedic care. Acute orthopedic injury care is typically occurring in 3 stages. Acute care is 0 to 4 days. Subacute care occurs in days 5 through 14, and post-acute care occurs after 2 weeks. The problem with these typical 3 stages is that the range of acute care is too wide. The treatment 10 minutes after injury is not the same as that needed 3 days after injury. Acute care, therefore, must be subdivided further. Injuries heal at different rates. There are different types and severities of injuries, and individual patient differences that we must address. Care should be dictated by patient's progress, not by specific timeframes. We've talked about RICE versus police. We use this for immediate care. RICE stands for rest, ice, compression, elevation, and stabilization, whereas police stands for protection, optimal loading, ice, compression, and elevation. For police, we protect the injury from further damage. Splint, wrap, or immobilize the injured site. If it is a lower extremity injury, crutches should be supplied. For optimal loading, this refers to determining and subsequently incorporating the appropriate progression from protecting the tissue to preventing exacerbation of the injury, to mechanically loading the tissue to facilitate healing. This is early functional activity that encourages early recovery. Extended periods of rest or unloading may produce adverse changes to the joint and tissue. Progressive loading mechanics of the injured tissue following acute injury facilitates healing. Ice. There is limited evidence that supports the use of ice. However, ice can be used to decrease pain and promote local vasoconstriction, which can help to control hemorrhage and edema. This lowers the metabolism in the injured area, reducing the oxygen demand and hypoxia. This can help prevent injury-related tissue death in the adjacent healthy tissue. This can be beneficial for acute inflammatory conditions such as bursitis, tenosynovitis, or tendonitis. This reduces the reflexive muscle guarding and spasm. Ice also produces an analgesic effect, which decreases the nerve conduction velocity. Typical treatments of ice that are less than 20 to 30 minutes have been proven to be ineffective. We need a reduction in tissue temperature, but that is dependent upon the type of cold application, the duration of the application, the thickness of the subcutaneous fat, and the body region. The application of cold for too long can also result in tissue damage. For the best results, ice packs such as crushed ice or ice cup massage should be used because they produce the most rapid and significant temperature decrease. Compression. Immediate compression of an acute injury is considered to be at least as essential as cold and elevation, and in some cases may be superior to them. External pressure on an injury assists in decreasing hemorrhage and edema formation by mechanically reducing the space available for swelling to accumulate. Multiple types of compression are available, such as elastic wraps, tape, and even commercial pneumatic compression devices. Compression wraps should be left in place for at least 72 hours after an acute injury. It has been demonstrated by research that using an elastic or plastic wrap to hold an ice bag in place significantly decreases the subcutaneous tissue temperatures. An elastic wrap that has been soaked in water and frozen in a freezer can provide both compression and cold when applied to a recent injury. Pads can be cut from felt or foam to fit difficult to compress body areas. Compression should be maintained throughout the day and, if possible, throughout the night. In many chronic overuse problems, the compression wrap should be worn until the swelling is gone. Elevation is used to eliminate the effects of gravity on the pooling of blood. This assists the venous and lymphatic drainage of the blood and other fluids from the injured area. The greater the degree of elevation, the more effective the reduction in swelling. Elevation should occur as often as possible during the first 72 hours of the acute injury stage. There are some immediate care myths that we need to discuss, such as acute care and immediate care are the same thing. Ice decreases swelling. The goal of immediate care is to decrease inflammation. The purpose of ice is to decrease hemorrhaging. Inflammation and swelling are the same thing. Ice should be applied for only 20 minutes during immediate care, and all injuries should be treated for the same amount of time. We'll try to discuss and dispel these myths during our course. Rest limits the injury aggravation. As early as we can and as safely as we can, we want to transition to relative rest. This is different from, but related to, stabilization. In the early stages of the injury process, we want stabilization. Stabilization provides structure and support to the injured structures. Often when we're talking about stabilization, it may include things like a brace. For ice and cold, limiting secondary injury and the neural inhibition are more important than controlling swelling. There are two theories, the circulatory or decreased blood flow theory and the decreased secondary injury theory. For the decreased blood flow theory, this is an older, more traditional theory. Cold decreases blood flow. The logic of the theory is that cold causes vasoconstriction, which decreases blood flow and therefore decreases the hemorrhaging and therefore swelling is reduced. The flaw is that clotting occurs before tissue is cooled enough to substantially decrease blood flow. More recently, the decreased secondary injury theory. The decreased secondary injury theory was first proposed in 1976, but was refined in 1985 and was tweaked again in 2002. This theory proposed that cold reduced secondary injury and limits edema. Cold decreases the cellular metabolism in viable cells, thus reducing the oxygen demand and consumption. This decreased secondary hypoxic injury results in less total injury and less free proteins generated by phagocytosis, which ends up resulting in less edema overall. The metabolism and cooling, there's a direct relationship, with more cooling resulting in greater decreases in metabolism. Heat increases metabolism, causing more secondary injury. Cold decreases edema, not hemorrhage. Most of the edema occurs hours after injury as free protein accumulates from phagocytosis. The cold limits the edema formation by preventing secondary injury and thus less free protein accumulation. Compression can help to control edema beyond the normal volume. For example, after the tissue spaces are filled. If applied consistently until swelling is over, it can result in less edema, and compression overall enhances cooling. Elevation decreases capillary hydrostatic pressure. Stabilization allows the muscles to relax, thus decreasing the pain spasm cycle. Stabilization allows the muscles to relax, thus decreasing the pain spasm cycle. There are numerous braces and splints available for stabilization. Stabilization also controls the neural inhibition. This is a process in which the neural pathway is blocked, so impulses cannot pass. This means that the intended function does not occur. This can be partial, so function is diminished, or total, so function is abolished temporarily. We need to talk about the physiology of heat transfer. We have conduction, which is the exchange of energy or heat between two substances in contact with each other. Heat moves from bodies of higher energy to bodies of lower energy. This causes the warmer body to cool and the cooler body to warm until they reach equilibrium. The rate of conduction is influenced by the temperature difference between the body and the modality, the regeneration of body heat and the modality cooling, the heat storage capacity of the cold modality, the size of the cold modality, the amount of tissue in contact with the pack, the length of the application, and there is some individual variability. The In heat storage capacity, there is a specific heat, the amount of heat energy required to raise 1 kilogram of substance 1 degree Celsius. For ice, that is equal to 0.5. For ice, that is equal to 0.5 calories per gram. For water, that's 1 calorie per gram. There is a latent heat of fusion. This is the amount of heat energy needed to convert a substance from a solid state to a liquid state without changing its temperature. There's a phase change. For ice to water, that is at 85 calories per kilogram. Crushed ice packs are better than gel packs. Gel packs need at least 22 kilocalories. The temperature changes resulting from cold pack applications. These include the surface temperature and the tissue temperature. For the surface temperature, repeated applications and the compression of the wrap over the cold pack can influence the surface temperature. The tissue temperature depends on the depth and the type of tissue that's involved. For the tissue temperature, there's a delayed response to cold. Additionally, deeper tissues are influenced by the amount of adipose tissue, and rewarming can take hours. The articular temperature is similar to tissue temperature changes with adipose tissue. There is a delayed response, and it continues to decrease after the application. This is dependent upon the amount of adipose tissue that the individual has. We need to consider the rewarming of tissues after cryotherapy application. This is dependent upon the activity level before cryotherapy application. Also upon the amount of heat removed from the body during the application. For example, the magnitude and the duration of the cold exposure. It's also dependent upon the amount of heat available to the rewarming area, such as the function of circulation and the environmental temperature. Some cryotherapy application procedures. Tissue cooling depends on cold modality used and how the modality is applied. Many protocols suggest the length, the frequency, and the duration of the protocols. There are many different factors that affect tissue cooling, such as the type of cold pack for heat fusion, the duration of the application. For the longer the application, we get more cooling and slower rewarming. The size of the cold pack, the larger the cold pack, the more cooling. The amount of tissue in contact with the pack. The more tissue in contact, the more cooling we're going to receive. The depth of the target tissue, the deeper the target, the less cooling. And the method of application, on the skin or over a towel or wrap. And do we have compression over the pack? There are different types of cold packs that we can use. There's 4 different types. Crushed ice, a gel pack such as a Chattanooga or a Kramer pack, artificial ice such as water and vinyl, also known as like a Duracold, or a chemical ice pack. These are often double bags and may be crushable, or they may be powder types. Crushed ice is the most effective because of the heat of fusion. This is excellent for on-the-field use because it doesn't melt for hours if it's stored in an insulated cooler. It should not be used if it's kept in a freezer because it may become too cold. Gel packs can become dangerous because they are kept in a freezer. Oftentimes, they're colder than regular ice. These can be dangerous if they're applied directly to the skin and can result in chemical burns, if they leak, or even frostbite if they're applied directly to the skin. We use a towel or other object in between the skin and the gel pack if we're going to use these types of modalities. Artificial ice. These are typically water in vinyl pouches that are surrounded by a nylon cover. One example of that is a Duracold. These are better than gel because of the heat fusion, but they're not as good as crushed ice because of the insulation from the nylon cover. However, these are great for home use. Chemical ice packs are often in double bags and sometimes are crushable. These often produce a chemical reaction when the inner bag is crushed and the contents react with the outer chemicals. This produces the least amount of cooling and is not recommended for use in therapeutic settings. Frozen peas are another option. These are popular, cheap, and convenient. They can be effective, and they're better than nothing in gel packs, but they're worse than crushed ice packs or ice water immersion. There's little phase change with the peas, and we need to avoid them in a clinical setting if possible. Our cold application protocol. If we can, we would like to apply our cold modality directly to the skin, not over a towel or an elastic wrap, except the only exceptions are if we're using gel packs or crushed ice that is from a freezer. The insulation decreases the effectiveness of the ice. The length of the application protocol. This needs to be intermittent, 30 to 60 minutes every 2 hours. We also need to consider the depth of the target tissue. This table can help us figure out the depth of our target tissue. With an individual with greater amounts of adipose tissue, we may need to leave the ice on for longer periods of time. The duration of the therapy. We need to think about the severity of the injury and transitioning from RICEs to cryotherapy techniques involving exercise. We also need to consider the purpose of our treatment. Are we trying to prevent versus removing swelling? What is the goal of our treatment? Are we trying to prevent secondary injury versus removing free protein from the extracellular spaces? If our goal is to try to prevent, we want to decrease the metabolism, and we need our cold to be effective. If our goal is to remove the free proteins, we need to stimulate lymphatic blood flow, and cold is not nearly as effective. If we want to remove the free proteins from the extracellular spaces, we need to stimulate lymphatic flow. This may require intermittent compression. We can also do this through the use of massage, a lymphedema pump, or active exercises or a muscle pump. Compression. Elastic wraps are preferred for compression. Research has suggested stretching the elastic wrap to approximately 75% of stretch as they're applied to the body part. Plastic wraps, such as Flexi Wrap, has not been as effective as ACE wraps have in research. The compression should be the same as if the wrap was applied first to the injury. Cryotherapy also has some contraindications and precautions. Cold can be dangerous if it is applied for too long or if it is too cold. We can also have some issues if it is applied with excessive compression. Individuals who suffer from some specific disease, such as Raynaud's phenomenon, cold hypersensitivity, or cold urticaria, also pose contraindications for cold cryotherapy. There's a 5-step application for the immediate care. These include the foundation, which includes the definition, effects, advantages, disadvantages, indications, contraindications, precautions, and then the pre-application tasks, which includes selecting the proper modality, preparing the patient physically, preparing the patient psychologically, and then preparing the equipment. The application parameters, including the procedure, the post-application tasks, and the maintenance. We'll discuss more of these details as we'll get into our labs for the class.